works as a clinical associate professor for Department of Global Health, University of Washington. We welcome you, sir, to today's session.
Thank you, Shweta, and welcome everyone, and good afternoon. Today's topic is transition to dolutegravir. So if you have attended the previous NDLS also on the similar topic, which was on the phase 1 transition when DTG was introduced into the national program. In this particular NDLS, we will be talking about the next phase of the transition plan, in which we will be going to discuss about the transition from ZLN regimen to the TLD regimen. And also we will be talking about the benefits of dolutegravir. Earlier, in the earlier phase of the transition plan, it was mainly the alternate second line and third line switches had happened or substitution had happened. And in this particular or at this particular time, we will be talking about substitution in from ZLN to TLD, and which will be by and large at the major almost all the ART centers. So it will be a kind of revision for the benefits of dolutegravir and also things related to that. And we will be talking about the special scenarios in which the dolutegravir dosage will be different, and also dolutegravir usage in the pediatric population. We will be also talking about the upcoming regimens which will be coming into the national program after complete availability of TLD regimen to everyone. So as it is just the beginning of the TLD combination, which will be which will be available at the ART centers very soon. So in the next, when the TLD will be completely available, the stocks will be sufficient enough. In phase-wise manner, NACO will be keep on sending office memorandums or the guidance letters, and based on that we will be doing this transition. So we will be talking about the upcoming regimen plan as well in this particular session, so that whenever an office memorandum is sent, you will be ready to substitute or switch from the earlier regimen to DTG based regimen. We'll also see how PEP will change post-exposure prophylaxis, and some notes for the ART center staff, especially the counselors. So this we had discussed earlier, phase 1 transition plan, for which a letter was released from NACO in the month of May or April or May 2020, and this was a letter which was sent. And as per this letter, the patient groups for DTG transition were two, which says that DTG means dolutegravir, which is an integrase inhibitor drug, and this will be initiated in the first phase in these two categories. Number one was all patients currently on raltegravir based regimen, and number two, it was patients who need to be switched to third line ART or to alternate second line ART. DTG will be preferred integrase inhibitor in place of raltegravir. So it was said that if you have raltegravir, first use that, and when raltegravir gets over, and then you need to use dolutegravir in place of raltegravir. What it means is, if the patient is currently on raltegravir plus lopinavir ritonavir based regimen, which is essentially an example of alternate second line ART, first of all, you need to do, for any substitution or switches, you need to do viral load of that patient first. And when you do the viral load test, and if you find the viral load is suppressed, then lopinavir ritonavir will be continued as it is, and in place of raltegravir, DTG will be given, dolutegravir 50 milligram OD. And if the viral load is unsuppressed, which means viral load is more than 1000 copies per ml, then the guidance is that all these patients will undergo step-up adherence counseling for the period of 3 months. And if their adherence is good, their viral load will be repeated. And if the repeat viral load is less than 1000, then again it will be continued as a suppressed patient or not in failure patient, and OD dose of DTG will be continued. And if the repeat viral load is more than 1000, then you will see here darunavir, ritonavir plus DTG. So as this patient has failed on lopinavir ritonavir, then the next recommended DTG based regimen will have darunavir, which is obviously a third line combination. And as integrase inhibitor was already used in before, in the next line of treatment, we will be using DTG, but in BD dose. So similar principle applies if you look at the upcoming regimens also, that which I think you should remember. If DTG is used in the previous line of treatment in OD dose, and if you want to further use the same DTG drug or dolutegravir drug in the next line of treatment, it will be in BD dose, double dose. So again, and raltegravir plus darunavir ritonavir, if this is the regimen, we again must do the viral load. If viral load is suppressed, less than 1000 copies per ml or TND, then the next line of treatment will be darunavir, BD, ritonavir BD, and dolutegravir OD. And if it is unsuppressed, then it will be used in again BD dose as it was before. When the patient is exposed to multi-NRTI regimen, for example, stavudine, lamivudine, tenofovir, so abacavir. So if the patient is exposed to multi-NRTIs, such patients will be given dolutegravir as second line drug or next line of treatment. If they are on these in second line, it will be lopinavir ritonavir plus dolutegravir OD dose. And if the patient is failing on second line ART, PI based second line ART, and who needs third line ART, darunavir ritonavir will be used along with DTG OD dose, because raltegravir was never used before. As you see that all these things were already discussed in the previous sessions or previous OM, and it was said because COVID was on peak and viral load was not happening, that is why it was said that if getting viral load done is a challenge, because especially because of the COVID lockdown and this particular scenario, then last viral load results can be used, which is done within the last 6 months, should be used for decision making. But I guess now viral load is happening in most of the ERT centers, so through Metropolis mechanism at least, so you can use the same mechanism for getting the recent viral load done. So the current office memorandum or office order which has been sent from NACO, which says switch from ZLN to TLD based regimen. If you remember, some time back there was a letter which was sent from NACO saying that you need to do viral load for all patients who are on ZLN based regimen. If those who might have seen that letter before might have started doing viral load since that particular time, but if not, now you need to do viral load of all these patients who are on ZLN based regimen. So this was the office letter which was sent from NACO on 7th of July this month, which says that you need to shift the patients from ZLN from TLD based regimen. Now TLD, I guess it is not available at all ART centers as of now, but it has reached SACs and the distribution has started from SACs, and ART centers should be able to receive TLD stocks very soon, those who have not yet received. So what this letter says in summary, those patients who are on ZLN based regimen, so you need to do again viral load for all these patients. As I said, again, if viral load is not available because of COVID, you just refer back to the previous 6 months or previous viral load, and decision can be made based on that. If viral load done and viral load is less than 1000 copies per ml, then switch to TLD as first line. This is very important to note, that even though when we are saying TLD in first line and also in second line, so it is important to note that whatever substitution or whatever switch we are making here from ZLN to TLD, it is being made as first line substitution or sorry, first line switch or switch to second line. So if viral load is done and viral load is less than 1000 copies per ml, that means the patient is suppressed on ZLN, and still we will change the ZLN to TLD as again continuation of first line itself. If the viral load is more than or equal to 1000 copies per ml, then the patient will undergo step-up counseling for 3 months, where intense counseling will be done for maintenance of good adherence and also overcoming barriers to adherence and all that. And when the adherence of the patient is more than 95% for 3 months, then viral load will be repeated. And if the repeat viral load is less than 1000, then this patient will be again continued on TLD as first line itself. If the repeat viral load is more than 1000, then this patient will be referred to SASEP for evaluation. And if SASEP finds that this patient has failed on ZLN based ART, then the regimen will be changed to TLD. But in this scenario, this change will be, or this new regimen is going to be started as second line. So in future slides, some of you might be thinking that after doing all this, we are changing from ZLN to TLD only here also, and here as well. TLD as first line, TLD as second line. But it is important to note that there is a huge difference between these two, which actually determines the next line of treatment for these particular patients. Because if you are giving TLD as first line, then in second line, you may have a different kind of regimen. And if you are using TLD as second line here, in the next line of treatment, that is third line, you will be having a different kind of regimen. So it is very important. That is why to note that if you are giving TLD to someone, you should know that you are giving this TLD as first line or second line. So in summary, if the patient is on ZLN, you get viral load done, viral load less than 1000, TLD as first line. You get viral load done for the patient on ZLN. If viral load is more than 1000 copies per ml, then you need to do step-up counseling for these patients, 3 sessions. If viral load is still more than 1000 copies per ml, then this patient will be given as TLD OD as second line. Now, important thing to again understand is why we are making all these changes. Towards the end, you will again realize that why this is so very important now to use this particular combination, that is TLD. So there are many benefits of using dolutegravir, one of which is rapid suppression or rapid and sustained efficacy of the regimen which we are using. So which means that if you are comparing dolutegravir based ART like TLD with efavirenz based ART, that third drug is we are very much concerned about, which is NNRTIs. So by doing all this, actually we are getting away with NNRTI based ART because of many studies which have been done in many countries, at least more than 10 countries, which says that the background resistance to NNRTIs is more than 10%. So what WHO recommends is if the background resistance to a particular group of drug is more than 10%, then you should not be using that drug as your first line, or you should not be actually using drug without doing resistance testing. In our program, we are using ART without resistance testing. And as there is enough evidence to say that the background resistance in India and similar countries, it might be more than 10%. That is why we are actually getting away with the NNRTI based ART. So, which means that we are getting away with nevirapine and efavirenz based ART. And this is the first benefit as per this single study, which says that the undetectable viral load, which is actually ultimate result what we actually foreseeing after starting ART, it is 88% in DTG based regimen versus 81% in tenofovir based regimen at 48 weeks after ART initiation. And if the same thing, if we compare at 96 weeks, it is 80% versus 72%. That means DTG based regimen are more efficacious than the NNRTI based regimen. If you look at the same thing in the context of the viral load suppression, the DTG actually suppresses the viral load in a PLHIV quickly. So if you look at the duration of the viral suppression and compare with the efavirenz based and DTG based regimen, so average 4 weeks for DTG based regimen it is required for suppressed viral load of less than 1000. And if you compare that with the efavirenz based regimen, it is about 12 weeks. So it is a huge difference from 4 weeks to 12 weeks. And what it means is if there is a faster virological suppression after initiation of ART, it actually reduces the risk of transmission also. And also in the patient himself or herself, it will again reduce the formation of multiple copies of the viruses. If you look at the same thing in terms of tolerability, so it is very much tolerable, and the side effects of DTG based regimen or side effect because of DTG itself, they are much lesser than efavirenz. Those who are experienced now, and you already know that one of the major reasons why our patients become lost to follow up, especially the new patients, is because of the side effects of efavirenz. It has psychological side effects. Some people, they feel giddiness, and also sometimes vivid dreams and suicidal ideations also. So efavirenz becomes a reason because of which many of the patients do not continue ART. And if you compare that with DTG based regimen, it is 2% versus 10% discontinuation rates, which is a huge difference between the two regimens, efavirenz based and DTG based regimens. At 42 weeks, this difference is 2 versus 10%. At 96 weeks, this difference was 3 versus 11%. Next important benefit of using DTG is having higher barrier to resistance. Barrier to resistance means in presence of a particular mutation, uh, um, whether a particular drug or virus population becomes resistant to that particular drug or not, or how many mutations are required. So this, I'll not go in details of resistance and potency and barriers, the mutations as such, but all these are acronyms of ART drugs. I just want to you to pay attention to some of the acronyms here, like zidovudin, stavudin, tenofovir. These are in terms of barrier to resistance and potency in the left lower quadrant, if I can say that. As compared to this, if you compare this with DTG, it is in right upper quadrant, which means DTG has and darunavir, they have highest barrier to resistance, which means it is very difficult for the HIV virus to become resistant to these particular drugs, even if they are not adherent. So, and also in terms of potency, it is very much potent, and as compared to the other drugs which we routinely use, these dolutegravir is much more potent than the other drugs. So this is the reason why we are promoting usage of dolutegravir, and why all the recent guidelines, they say that dolutegravir should be your first line of treatment. Highest genetic barrier to resistance, and also one of the highest potent drug in the ART regimen. Now, before 2018, everything was good and everyone was very happy about dolutegravir, but something happened in 2018 where the people started doubting its usage, especially in pregnant women. What happened was in Botswana, which is a South African, it's a African country near South Africa or bordering South Africa. Uh, there was a study which was done and which involved actually the 8 largest maternity wards, and which says that and as per the early analysis of the data from that study, they identified 4 neural tube defects out of 426 pregnant women taking, or 426 women taking dolutegravir at the time of conception. Means when they conceived, when they become pregnant, and they were on dolutegravir based regimen. And in those women, out of 426, 4 babies were found to be having neural tube defects. Now, what is neural tube defect? Neural tube, first of all, what is neural tube? Neural tube is actually an embryonic precursor to the central nervous system, which is made up of brain and spinal cord, which means when baby's brain and spinal cord is made, before that there will be a neural tube which uh, uh, is formed, and from that neural tube, brain and spinal cord are made. Now, this neural tube actually closes by 28th week of pregnancy, 28th day of pregnancy. That means first month itself, it actually closes. And after that, there is no effect on neural tube. So what happened is, when they saw this 4 neural tube defects out of 426 women who were taking DTG at the time of conception, red alert was actually highlighted for usage of dolutegravir in women who were of the age of pregnancy potential. So the percentage wise, if you see, it was 0.9%. And from that point onwards, the data is being collected on in such particular population, which is having pregnancy potential, or women having pregnancy potential, and it is being further studied. The data which was updated in 2019, it showed that the prevalence of neural tube defect has been further reduced to 0.3%, which means out of 1,000 women who were actually on dolutegravir at the time of conception, just 3 actually had neural tube defects in their babies. Now, this difference remains significant or statistically significant as compared to efavirenz, but overall risk, if you see, it still remains low. This data is further being collected, so the denominator, that out of how many exposed, is going to get increased day by day, and we will get again further firm up data as time goes along. So in all, this was important to mention that this is one particular thing which has been under discussion since last 2-3 years, but the newer data which is coming up, it just says that it is more safe and safe. It actually supports the safety of dolutegravir, even this particular age or group. So, however, it is safe to initiate dolutegravir based regimen in pregnant women beyond first trimester. I would say that because neural tube closes after first month of pregnancy, because it closes by 28 days. After that, it should be safe to use dolutegravir. So, but still, if this is from the WHO policy brief of 2019, which actually compares the risks versus benefits of dolutegravir use in women of childbearing potential. So, the benefits of DTG clearly, as we discussed before in the previous slides as well, they include greater maternal viral suppression, fewer maternal deaths, fewer sexual transmission, and fewer mother-to-child transmission of HIV. And risks, you can say that dolutegravir, one of the side effects of dolutegravir is weight gain. So in our population particularly, it may not be of big concern, but still what they say is because of this weight gain, there can be again, in some patients, they face neonatal deaths. So, but what WHO has done is, out of all this data, they have compared the risks versus benefits, and what they have concluded is that the risk benefit model suggests that benefits of DTG for women of childbearing potential newly initiated on ART likely to outweigh the risk associated with it. So this is the reason we should not be having a blanket exclusion that deny the women equitable access to this optimal HIV treatment, and we should ensure that all women or everyone actually should get benefit of this particular drug. Why I'm saying all these things in detail is because, especially to the counselors and also obviously for the doctors, when they initiate ART in women of having pregnancy potential, so all these things need to be discussed with them in a positive manner. So it should not be said that every woman who is in this particular age group or who is in having pregnancy potential is at risk of neural tube defect. The answer is no, because you need to understand the complete issue, and accordingly you need to explain this to the patient so that they can make an informed choice. So, but if suppose for some reasons, if they are not willing for starting ART or DTG based ART, and if they are in of childbearing age, then effective contraception should be offered to these adult women, and DTG can be prescribed for women and adolescent children of childbearing age who wish to become pregnant. So it clearly says that it is not a contraindication in the women of childbearing age group, but everything need to be explained properly. And those who are not willing to avoid unplanned pregnancies, you may offer them usage of contraception methods. So in case a woman does not want to initiate TLD after adequate counseling, the next option available with us will be TLE. So if women is identified to be pregnant after the first trimester or maybe after first month, then DTG should be initiated or continued to the duration of pregnancy. There is no question of neural tube defects in these particular women. So in summary, what we have discussed till now is DTG is very good for rapid viral suppression, which not only benefits the patient, but also reduces the risk of transmission from that particular patient to other sexual partners. Then fewer toxicities and side effects, especially if we compare that with the efavirenz, and in turn resulting in good adherence to ART treatment. more potent regimen. So it also is beneficial in terms of its effect for prevention of mother to child transmission of HIV as well. Because of viral suppression immediately happens, the risk of transmission from mother to child also is reduced very rapidly. Minimal drug interaction. This drug has very minimal drug interaction, but the most common drug which we use for HIV along with ART is anti-TB treatment, where rifampicin is used. So it interacts with rifampicin. So the next choice is either we use rifabutin or we use dolutegravir in double dose. So I'll come back to this particular point later as well. It has very high genetic barrier to resistance. As I said, it is difficult for the virus to become resistant to this particular drug. It can also be given safely to HIV-2 patients. Unlike NNRTIs like nevirapine and efavirenz, we were not able to use in HIV-2, but DTG can be used in HIV-2 also. Harmonization across patient populations. This can be used in children, this can be used in women, elderly, adolescents, boys, male, and everyone. So that makes our job very easy as a clinician and program managers as well. We'll see numbers supporting that later in the later part of presentation. Just quickly, mechanism of action of DTG or dolutegravir. Similar, if you remember the classes of ARV drugs, so dolutegravir belongs to integrase inhibitor class, and from the same class, we have been using raltegravir in second and third line before, and now DTG has come up from the same class of drugs. So if you remember the life cycle of HIV virus, when the double-stranded RNA is converted, single-stranded RNA of the HIV is converted into double-stranded DNA by reverse transcriptase enzyme, which actually is the target for most of the NRTI and NNRTI drugs. And this proviral DNA is integrated into the human DNA by the integrase enzyme. So this also is a very important step in HIV multiplication. So the drugs actually which inhibits the action of integrase enzyme are called as integrase inhibitor. So dolutegravir, being an integrase inhibitor, actually acts here on this step of viral multiplication, and that is why it is really crucial. Some adverse effect of and drug interactions of DTG. By far in India, this has been used in private sector, but in government sector, obviously in the program, this has been very recently introduced. So we all need to be very vigilant on side effect of the dolutegravir drug. So as per the international evidence, what we have, these are the side effects which have been enlisted by through international evidence, that is insomnia, that is disturbed sleep, headache, dizziness, tiredness, allergic reactions, and DTG associated weight gain. And what WHO recommends is WHO recommendations also highlight the importance of healthy diet and regular exercise to help manage weight of all these patients. Now, please remember that these are the side effects which have been reported globally. So not necessarily our population need to have the same side effect. That is why since the beginning also all ART centers should be very vigilant on the side effects which our patients are showing, so that we can document them better and we can take decisions accordingly. So, but good thing is that majority of the patients will not have any side effects, but those who may have side effects, these are the enlisted one by far. When it comes to drug-drug interaction, some of the commonly used drugs, especially these antacids, having calcium and also magnesium and some of the multivitamins with zinc or iron, these are the drugs actually which interacts with dolutegravir. That is why if our patient is on any of these drugs, they need to be clearly said that they should use these drugs either 2 hours before or 6 hours after taking dolutegravir. Other drugs which are again commonly used are metformin. The dose of metformin should not cross 1000 milligram if that is being used along with DTG. It is one of the oral hypoglycemic drug which is used in diabetics. The other drugs which are anticonvulsant drugs like phenytoin or carbamazepine, if it is being used with carbamazepine, then DTG twice a day need to be used, and if phenytoin should not be used, alternate anticonvulsants can be used. Along with usage with rifampicin, as long as the patient is on rifampicin-based anti-TB treatment or drug, the DTG should be used twice a day. And when rifampicin is stopped, again, it should be given as an OD dose. So by far we have seen what is dolutegravir, what are the benefits of dolutegravir, how effective it is in HIV positive population, and overall benefits of the drug. And also we have seen that up till now, or at this point of time, the NACO's guidance on usage of dolutegravir based ART in the alternate second line and third line in place of raltegravir, and now switch from ZLN based ART to dolutegravir based ART. So I'll show you a few slides also that in future there will be upcoming regimens and how these switches will happen. So these are the proposed NACO regimens, DTG based regimens. Basically, whenever and as and when this you will be asked to do those substitution, please follow those NACO guidance documents very carefully, because it is linked with your existing stock of ART. So even though I'm showing you now upcoming regimens as well, you won't substitute or switch these drugs to dolutegravir based regimen unless NACO sends a specific letter in relation to that particular regimen. So up to now, as I said before, it is all for alternate second line and third line in place of raltegravir. And also very recent, as per very recent office letter of NACO, it is for ZLN based regimen, which will be switched to TLD based regimen. So for existing patient, whenever you want to do this switch, you will have to have a viral load available for that particular patient, so that you know that the switch you are making is as a first line switch or second line switch, because of the reason which I mentioned you before. So dolutegravir based regimen for treatment of HIV positive adult, adolescent and children, and it can be used for anyone who is weighing more than 20 kg of weight and age more than 6 years. So dolutegravir based regimen are preferred first line in the NACO program for new PLHIV as well as already on ART, and and uh, and selection of appropriate regimen would depend on viral load suppression status of the PLHIV, and it will be done in phased manner, as I said before, because we already have a huge stocks of TLE available with us, and also likewise the other drugs. So NACO takes that decision considering the existing stock situations. That is why please don't take any decision at the ART center level. So as and when the guidance comes from SACS and NACO, you need to follow that guidance for making substitution and switches. So this will be the upcoming first line preferred regimen, that is tenofovir, lamivudine and dolutegravir 50 milligram, and this will be a TLD combination. As I said before, we will be able to use the same combination for almost all our populations of HIV-1, HIV-2, HIV-1 and 2, women exposed to nevirapine in the previous pregnancy as a part of hepaticity regimen, those who are co-infected with hepatitis B and C, and also women of childbearing age group, unless if they are excluded. So if the weight is less than 30 kg, then we will not be able to use actually tenofovir. And because tenofovir cannot be used, that is why in place of tenofovir, abacavir will be used, and the combination will be abacavir, lamivudine and dolutegravir OD. And all patients with high creatinine values for their particular gender and weight, which will be given on their report chart. If that is the case, we need to calculate the creatinine clearance, and based on that, lamivudine dose need to be adjusted. And here, the individual drug of abacavir and DTG need to be given. In special situations where we use rifampicin, like I said before, tenofovir lamivudine will be used OD, or TLD combination will be used in the evening, and in the morning additional DTG dose will be given, and this will be done as long as the patient is on rifampicin based ART. And once the patient completes the TB treatment, then OD dose will be continued. And females in reproductive age group who opt out of TLD, who do not want to take TLD because of the reasons which I mentioned before, then the option is TLE. And if the Efavirenz is contraindicated in such patients because of previous exposure to nevirapine in the previous pregnancies or HIV-2 or HIV-1 and 2. Then lopinavir, ritonavir will be the next choice. So the second line regimen will look like this. If the first line contains zidovudin, and if the patient has failed on NNRTI or PI based ART, for example, ZLN, ZLE, ZL lopinavir, ritonavir, or similar regimen, then the second line for this patient will be TLD. As zidovudin was used in first line, in second line we are using tenofovir. PI or NNRTI was used in the first line. In the second line, we are using dolutegravir. Now, this TLD here we have used as second line. And if tenofovir is contraindicated because of the nephrotoxicity or renal toxicity, in place of tenofovir, we will be using abacavir. Now, tenofovir, abacavir containing first line ART, obviously this in second line you will be using zidovudin. And if you cannot use zidovudin because of anemia, then you will have to use lopinavir, ritonavir. That I'll come to. And if this patient is on NNRTI based first line ART, then the second line for this patient, as tenofovir or abacavir was used in the first line, second line will be zidovudin based. And if PI was used as first line, then again ZLD will be in the second line. But the difference comes here if this patient has anemia. So if this patient has anemia, we will not be able to use zidovudin. And in place of zidovudin, if the patient was given NNRTI based first line, for example, nevirapine and efavirenz, then obviously in the second line, we will be using lopinavir, ritonavir along with dolutegravir. But if the patient was given protease inhibitors like lopinavir in the first line itself, and if this patient fails, then the next drug will be darunavir, ritonavir in addition to dolutegravir. If obviously because of anemia, we are not able to use here zidovudin. So this is the main difference. That is why it is important to note what was given in the first line. Based on that, the second line is formed. And now when we are starting the TLD as first line itself, and this will continue now as and when NACO sends OM regarding this, and we are hoping that for a long period of time, these patients do not or will not fail on ART. But if they do so, if they fail, so what second line for them becomes is ZL plus atazanavir, ritonavir. So this will be the combination which will be they will be having, that is PI based second line. And if they are on ZLD combination as first line, and if they fail, because zidovudin was used in first line, in second line you will be using tenofovir, TL plus atazanavir, ritonavir, which means the preferred second line protease inhibitor will be atazanavir, ritonavir. But one basic principle we should remember, that atazanavir actually interacts with the integrase inhibitors. That is why atazanavir actually is not used if you want to use raltegravir also before. And those, if some patients are on that regimen, raltegravir plus atazanavir, ritonavir, that is not a good regimen. So whenever you want to use integrase inhibitors like raltegravir or dolutegravir, better than using atazanavir, it is lopinavir, ritonavir. So that is why if in the even though preferred second line here is this, but if the patient is anemic and if you want to use dolutegravir, and here dolutegravir was already used, as first line, that is why in second line you will be using BD dose of dolutegravir. But as with integrase inhibitor, we cannot use atazanavir, ritonavir. That is why it will be changed with lopinavir, ritonavir. So your second line regimen will look like dolutegravir BD plus lopinavir, ritonavir if this is the scenario. If the patient is exposed to multi-NRTI, like I said before, zidovudin, lamivudin, stavudin, or tenofovir, like if the patient has been exposed to all, and if this patient is on NNRTI based third drug, and if this patient fails, it will be dolutegravir plus lopinavir, ritonavir, and PI based first line, then it will be because lopinavir was already used in first line, you will go one step up. So that is why you will be using darunavir, ritonavir in such cases. Patients who are co-infected with TB receives BD dose of DTG as long as they are on ATT because of rifampicin. And once that is over, again OD dose will be continued. and those with hepatitis B will continue. And if they are not on tenofovir, they will be continued on TL-based ART as a for hepatitis B treatment. As for third line, again, third line regimen should include this is the basic principle of third line, that they should include the new drug, at least of one class of new drugs with minimal risk of cross resistance to previously used ARVs. So integrase inhibitor with new boosted PIs is the best combination. So with that, and third line can be started by these COEs, but with SAC's permission and NACO's permission, some of the ART plus also will be equipped to initiate third line ART if the drugs are available with them. So that that actually permission will be sought from SACs or respective state aid control societies. So the regimen or preferred regimen for the third line will be dolutegravir 50 milligram twice a day, plus darunavir ritonavir 600 milligram BD and ritonavir 100 milligram BD. So DTG will be used in OD if the drug was never used before. So even though in third line as well, if dolutegravir was never used before, it will be used in once a day dose. If it was used before, it will be given as a twice a day dose. If this patient is co-infected with hepatitis B, then tenofovir will be added for the treatment of hepatitis B. For pediatric age group, again, as I said before, if the child is more than 20 kg age, or more than 20 kg, or age is more than 6 years of age, abacavir, lamivudine, and lopinavir ritonavir will be the preferred combination. Now, this can be easily actually seen with this can be actually easily seen in this particular flow chart. When the child is confirmed HIV positive, for example, then we treat and stabilize the acute whatever infections if the child has. And when it comes to ART initiation, we need to see that if the child is more than or 6 years or less than 6 years of age. If the child is less than 6 years of age, obviously here we will not be able to use dolutegravir. That is why here we will have to use lopinavir ritonavir as the third drug. And 6 years, less than 6 years and less than 6 kg. So abacavir, lamivudine, and lopinavir ritonavir will be the combination of choice for this particular group of patients. If the child is between 6 to 10 years of age, and here we can use, because age is more than 6 years and weight is more than 20 kg, you can use dolutegravir. That is why ALD comes in. If the age is more than 10 years, but weight is less than 30 kg. Now, in this particular age group, you can use dolutegravir, but you will not be able to use tenofovir in such patients. And that is the reason, as you won't be able to use tenofovir, you will be using abacavir in this particular patient age group or group. So abacavir, lamivudine plus dolutegravir will be the combination. And if the weight is more than 30 kg in these patients, if they have known renal issues, again, tenofovir cannot be used, then abacavir will have to be used. And if there are no known renal issues, then TLD will be used in those particular children. So it is very easy flow chart. Please remember as a summary that dolutegravir can be used in children who are more than 6 years of age and weight more than 20 kg. And tenofovir cannot be used if the age is less, if the weight is less than 30 kg and if the age is less than 10 years. So that is why all these permutation and combinations. But please again remember that all this information right now which we are discussing is for knowledge sake. Whenever NACO sends an office memorandum or official letter, then only all these things need to be implemented. So in HIV TB co-infection, like we discussed, DTG will be in dual dose, and also in pediatric age group, we may need to use super boosting of ritonavir if it is required. For post-exposure prophylaxis, current regimen is TLD or TL lopinavir ritonavir combination is the current preferred combination, but that will be changed to TLD whenever TLD is available. So that will be again communicated by NACO. Duration of ART for PEP and everything remains same as per the PEP guidelines, post-exposure prophylaxis guidelines. So PP in children, ZL is again recommended as preferred drug. So AL is recommended if HB is less than 9, and TL can be given if the child is below 10 year, about 10 years of age, and weight is above 30 kg. And third drug option will be lopinavir ritonavir if less than 6 years, and dolutegravir if it is more than 6 years. So finally, few points for the ART centers to remember. The available stocks of raltegravir should be utilized first. This is as per the first letter from NACO. DTG in BD dose for HIV TB patients need to be used, and the additional dose need to be given in the morning. And if when the patient completes the 6 months of anti-TB, it should be discontinued. In children, if the weight of child is more than 20 kg and age is more than 6 years, in them raltegravir, if they are on, that need to be replaced with dolutegravir OD. Especially for the counselors, all PLHIV transition to DTG based regimen to be counseled and informed about rationale for transitioning to a newer regimen. So all those benefits which I explained you, that we are because of efavirenz induced toxicities, people were becoming lost to follow-ups, and now they won't become. There are very less number of side effects because of dolutegravir based regimen, and also its potency in terms of reducing quick reduction in the viral load, reduce risk of transmission of HIV from mother to child, and also higher barrier to resistance, because of which there are less chances of regimen or treatment failure. So all these benefits need to be explained to the patients. And then for the patients or the women who are in pregnancy potential, the risk of neural tube defect in a language which they can understand, that need to be explained. And also it need to be explained that how the benefits of DTG actually outweighs the risk of DTG, which was mentioned before. So additionally, those who do not want to become pregnant, we need to talk about the contraception methods if they want to avoid pregnancies or unplanned pregnancies. And also, if they become pregnant, or if they are already pregnant, and if they are after the third trimester, it has to be continued as it is. So there is no risk of DTG toxicity in those patients. So sessions like this or even in-person trainings will be done whenever it is suitable. And for the counselors and pharmacists and other staff and data managers, one separate trainings may be conducted. I guess after the previous NDLS, there was many COEs did RDLS in local languages also. So similar sessions can be continued to be done after this particular NDLS, to explain everyone regarding benefits of DTG and what is the new what is this new regimen, and how important it is for us to know and for our patients to know about the details of this particular regimen. The necessary changes also have been made in blended clinical training curriculum. So those medical officers who are under BCT training as of now, they will be seeing information regarding DTG as well. Sessions like this will continue to happen, and along with that, again, the IC material related to and job aids for the ART center staff, some of which might have already been sent by NACO to you, and if not, very soon it will be sent to all the ART centers for quick reference by the counselors and other staff, so that they can easily explain the benefits of the DTG based regimen to their patients, and also do proper counseling of them before they put those patients on DTG based regimen or DTG based ART. So this is my final slide. After that, we can take some questions if you have. This is just to show you the regimen-wise distribution of PLHIV as per the March NACO MPR. So if you look at, the majority of our patients are on TLE, that is 64%, and ZLN, it is 24%. And rest of the patients, it is just 3%, 2%, or 1%. And if you look at the total number of regimen our patients are on, these are more than, at least there are 14 different types of regimen we at ART center we deal with in terms of their stock maintenance, and also monitoring of those patients who are on different various kinds of regimens. So, and everyone understands how difficult it is for the ART center staff. And what will happen after complete transition from the existing regimens to DTG based regimens is you will have to deal with only 6 or maybe 7 types of regimen after the complete transition happens to DTG based regimen, from 14 to just 6 regimens. So but because now we have stocks of all the drugs, which is being closely monitored by NACO and state AIDS control societies. That is why all these stepwise transition plan is being implemented. So in first phase of the plan, you were clearly said that the individual DTG tablet which was received at ART centers need to be used for the patients who are already on dolutegravir as alternate second line or third line. And now in this particular phase, it has been asked to the ART centers to switch the patients from ZLN based regimen, that is we are now talking about this 24% of the patients, patient group, to TLD based regimen. And obviously, if you have not received TLD yet, you will receive it very soon. It may be in transit. SACs might have received till now. And as soon as you receive, based on the viral load criteria, you will switch the patients to TLD based regimen with adequate counseling. So I'll leave it here, and every ART center need to look into their own data to come up with this particular information, that how they plan to do these switches, and this has to be very smooth at ART centers. And also, like I mentioned, as the data on the side effects is very limited in India, at least in the national program, because it is first time which is being used. So we need to be very vigilant, and we need to document the side effects if there are any for all these patients who are being started on dolutegravir based ART. So thank you. Those were the slides from my side. I would request Shweta, if there are any questions in the chat box, please let me know so that we can discuss those questions.
Yeah, so can I share my screen, please?
Dr. Anwar, thank you very much.
Oh, sorry. Yeah.
That was a wonderful presentation. I mean, we have tried to put in the operational as well as the technical part of it. So, I'll request Shweta to take up all the questions that were there in the chat box plus others, so that we can prepare an FAQ for sending it to all the ART centers. Thank you.
Thank you, Dr. Chinmay. So we will try to answer some questions here as well. And all those questions, as Dr. Chinmay mentioned, we will try to send that as FAQ for future reference for others as well. I'll stop my screen share so that Shweta can share. So I would request Dr. Chinmay and Dr. Reshu and Dr. Suman and others also to join in answering the questions if there are any program related questions, or if you want to add anything to it. I'll just quickly try to address the enlisted questions here, but please feel free to add or to any of the answers. So do we need to finish our ZLN stock first at the ART center? I guess all the ZLN stocks are depleting as of now, and we don't have enough stock of ZLN at all the ART centers. And if they are on ZLN, whatever is remaining, you need to finish it up. So if patient is having tenofovir toxicity.
Sorry, Dr. Anwar, I just want to add here. So I think ART centers need to be mindful of planned transition, because some of your patients might not be suppressed on ZLN and they might need a step-up counseling for 3 months. So you have to ensure 3 months of stock of ZLN for these patients. So whenever you are doing the transitioning of patients, please see your stock and see your patients what is the viral load suppression rate in these patients, and for how many patients you can do immediate transition, and for how many patients you will need to actually maintain stocks at least for 3 months to continue them when you're doing the step-up counseling.
Thank you, Dr. Reshu. Next is, if patient is having tenofovir toxicity, So if the patient is having tenofovir toxicity, as we mentioned, in place of tenofovir, we will be using abacavir, but this will be done if the, again, after calculating the creatinine clearance. So if you are not able to use tenofovir, we will be using abacavir in place of tenofovir. Do this drug derange lipid profile, blood glucose? As per the present evidence, we don't see any direct derangement, and we are not monitoring lipid profile for usage of this drug also. But obviously, blood glucose and all those things we monitor as it is recommended by the program, but not especially for this. Patient counseling is an important. As ZLN, we are giving MMD 3 months. So now after transition counseling is very important. Why are we switching currently giving 1 month? Why? Very important. Why are we switching and currently giving 1 month dispensation? Yeah, I completely agree with you that it is really important because we are already giving MMD. And when we start with TLD, we will be using monthly drug, I guess, to begin with. Dr. Chinmay, you want to add here that MMD will be?
I think it will depend on two factors. One is if what is the stock of TLD they have received. The other is viral suppression of the patient. And the third is please wait for a OM from NACO on this MMD for TLD.
Thank you, Dr. Chinmay. Next is it necessary to take consent of the female patients regarding neural tube defects? Not all female patients. The women who are in pregnancy potential, that is that age group in which they might become pregnant. So those patients, if you want to, even if they are not pregnant as of now, but if they may become pregnant, if they are in that particular potential, from those patients, all these things need to be discussed, and then it need to be started.
So just to add here, a written consent is not required. You need to adequately counsel the patient on the benefits as well as risk of DTG, and then whatever decision patients take, that has to be respected. Also, I just want to add here, because I mean I saw some other questions also in the chat box regarding the risk of needle tube defect. Now, as Dr. Anwar was saying, a newer data is also available, and it was discussed in the IAS 2020 conference also, and where they followed a cohort of 39,000 pregnant women, and now this data shows that the risk of needle tube defect if the women conceive while on DTG has further decreased from 0.3% to 0.2%. So I think as a provider, as a healthcare provider, as a medical officer, we need to have confidence in the drug whenever we are prescribing it to our patients, and we have to give them adequate counseling. And I mean, our counseling has to be a very balanced kind of act and giving a very neutral message to our patients in terms of the benefits and risk, because we don't want to deny women outrightly of the benefits of DTG. We know that DTG is a better drug. It has a very high drug resistance barrier, and obviously the benefits are more as compared to the risk of DTG. So I think that's something we should keep in mind when we are counseling our patients.
Thank you, Dr. Resho. That was really helpful because the recent data which we did not display in this presentation, and thanks for adding that up. Next question is, can it be used in diabetic mothers as fetal macrosomia and weight gain is already there? One of the slides we had mentioned that in the risk of DTG usage, it was mentioned even in the WHO policy update as well, that there is a risk of the fetal deaths or the malformations as well after usage of dolutegravir based ART related weight gain. So I think there is no contraindication as such as of now. So I have not seen any written contraindication as such in these women, but obviously these women will have to be monitored closely. Next slide, Shweta, if there are any more questions. Okay, these are already answered, I think, right?
Yeah, so is it visible?
Yeah, it is visible.
Yeah.
So if we use DTG as second line, it is to be given 50 milligram BD as viral load is more than 1000. If it is being used as a second line, as we have mentioned, it is need not be every time it need not be given as BD. Please remember that basic principle that if dolutegravir is already used in the previous line of treatment, and if you want to use in the next line of treatment, then only it need to be BD dose. Otherwise, even in the third line ART, it may be used OD dose if it was not used in first line or second line ART. If you remember like that, it will be easy. With anemia, can lamivudine will be continued or only dolutegravir plus lopinavir? So yeah, so lamivudine, especially we were giving along with the other drugs in the second line because of the other benefits of lamivudine. But here, if we are not using NRTI drugs, so we use dolutegravir plus lopinavir ritonavir directly. So we need not use separately additional lamivudine. Women already on DTG will come to know her pregnancy only when she misses her next period. So the fetus is already exposed to DTG. Yeah, this is the reason why we, after like, especially after first trimester, there is no point in actually withholding DTG. It need to be continued as it is. So this is, this main counseling is basically for those women who are in pregnancy potential. So they need to be actually counseled more. Any more, Shweta?
So please give me 2 minutes.
I think there's a question about like when the dose for TLD to be taken.
Yeah, dose of TLD will be OD dose, and we are saying that it need to be taken in the evening, and it is not necessary that they have to take in the evening, but it is better if they take in that way, because many of our patients are on tenofovir also, and in future on TLE as well, and in future they will be continuing because they are already on the evening dosage. So that is why we are saying that they need to take evening dose of TLD, and additional dose can be taken in the morning.
Yeah, so there's a question, what is the incidence of allergic reaction with DTG?
I'm not exactly aware of incidence of allergic reaction as such, but at least in Indian population, I don't think there is any documented evidence for that. So in fact, it depends on us how carefully we document all these side effects or adverse effects because of DTG, so that we will generate some evidence on that.
Yeah, the side effects of DTG are not very well documented right now. And the biggest cohort study which we have from Brazil, it shows that the overall incidence of side effects was only to the extent of 1.5% to 2%. So like generally we don't see that much side effects for DTG based regimen.
And
we don't have data from Indian population, so that's something I think when we start rolling this out, we should start documenting also, like if our patients have any peculiar complaints after a rollout of TLD or DTG based regimen.
Yeah, there's a question, is NACO going to supply abacavir 300 and lamivudine separately for the patients with renal disease?
As per current mechanism goes, it is through COEs, they actually procure special drugs if they require. But I think through SACs, it is again, every SACs has their own mechanisms how to buy the individual drugs and give it to the patients. Obviously, the number will be less. That is why it will be procured and supplied by SACs through COEs at most of the places, but directly from SACs also at some of the places.
Yeah, there's a question. What is the procedure for the private ART started on DTG-based ART already?
Likewise, what we are doing right now, if the patient is started on in the private, if we have the same regimen available in the government program, usually we continue with the same regimen. If obviously the regimen is rational. So the same method will be continued here as well. If the patient was started on DTG-based treatment in private, in the ART centers, we will continue with the DTG-based regimen.
How recent does the viral load report have to be for switching to TLD-based regimen?
So it is within 6 months. If it is there, that is really helpful. But if it is beyond that, you need to repeat the viral load and again take the decision.
Okay, there's a patient on TLE regimen on night duty wanted to change the timing of TLE because he was not getting adequate sleep. Can we change on TLD after OM from NACO?
For now, it is we need to wait for the next substitutions. Because again, I would say that this will be earlier guideline was from TLE. We actually used to substitute that to the TLN based regimen. But I guess in the individual patients with specific scenarios, if you want to take that decision, I think it should be fine. But we need to be very mindful of the stocks or supplies which are being given to us. So if it is, and that decision has to be taken very carefully, I would say, to say the least.
I think this has already been answered. What is the period of fresh viral load?
Yes.
Will LAC be allowed to dispense TLD if it's given as first line?
Yes. So when it will be available, it will be available for the entire population, including LACs.
Okay. Can DTG be safely initiated in patients with slightly elevated ALT and AST levels, as in case of alcohol-induced hepatic involvement?
So right now there are no contraindications as such for deranged liver functions, so it can be given.
In the current COVID pandemic, many of our ZLN patients are not having good adherence. Should we do viral load for them also?
Right now, I think viral load is being asked for all the patients to be done. So, and once you do the viral load for these patients, you will know that what is their viral load if they are, and also you will know that their adherence is not good if they are not saying it to you as well. And you get the opportunity of doing step-up adherence counseling for these patients. So next 3 months, you can monitor them closely. Anyhow, you are going to repeat their viral load after 3 months. After which you will know that how is the if it is suppressed or not suppressed, and you will know whether ZLN is
there's a
working or not.
question.
Yes, please.
Yeah, there's a question which has already been answered by Sudhir sir. I'll just ask the question. Why is it that DTG transition only for the virally suppressed ZLN patients and not for those who are not virally suppressed on ZLN?
Yeah, I think we have discussed that in detail. Yeah, and Sudhir has already explained.
Weight gain as a side effect can affect lipids, blood glucose. It's a statement. I'm not sure if it's a question.
Okay, you can go to the questions, I think.
Yeah. Okay. Why most of the doctor recommend TAF combination in place of TDF? What is the difference?
TAF and TDF, there is a main difference is TAF, tenofovir alafenamide, does not have renal toxicities, which tenofovir disoproxil fumarate has. And this is one of the drug which is right now very commonly being used in private also because of the main benefit of not having nephrotoxicity, which is there with in some patients with tenofovir. In the national program, it is not available, and also the usage in the for the like as a preferred first line as a general guideline, it is not there. So it is not there in the program as yet. We don't know about the future, and that is the main difference between TAF and TDF.
Yeah. Interaction with other drugs has already been explained. For normal with no comorbid patients, what would be the preferred time for TLD? Morning or night, after or before food? Anything in particular to be followed?
As we discussed, I think this point also was discussed. We will be recommending TLD in the evening. And there is no specific as such before or after food. Only thing, as we said, that many of our patients might be on antacids or multivitamin drugs, and in that case, we need to ask them either 2 hours before or 6 hours after food, after taking that particular medication.
Okay. Dose for children with 50 mg or less. Dose for children will be 50 mg or
50
less.
mg. It will be 50 mg because we are giving only to the children who are weighing more than 20 kg of weight.
What are the implications for deranged LFTs?
In deranged LFTs, again, it has to be discussed with I think the decision need to be carefully taken, because there are some reports where it has been mentioned that it need to be carefully seen. So there cannot be a general answer for this. I think if the LFTs are, if the renal functions are deranged, in those cases, because we are here giving tenofovir also in the combination, that decision will have to be taken on case-to-case basis, I say.
What regimen to be given in first trimester?
First trimester, the preferred regimen, again, as per the recommendation, it will be again TLD. As we said, the complete picture and complete discussion has to happen. And if they want to opt out of TLD, then TLE can be in the next treatment.
Any lab investigations to be done for monitoring patients on DTG?
No specific lab investigation as such.
Okay, should TLD be discontinued if a woman opts to be conceive or pregnant?
That depends on, again, the duration of the pregnancy. If hardly it is likely that it will be diagnosed before first month or before 28 days of the month. And as I said, neural tube actually the development completes by 28th day of pregnancy. So usually what happens in the common scenarios, when they know that they are pregnant, it is already more than 1 or 2 months. And after that, I think it can be safely continued.
Yeah, the question is, in case she wants to become pregnant and she is on TLD, should the TLD be stopped and some other regimen recommended?
Yes, in those women only, those who want to become pregnant and those who are on TLD, the whole discussion has to happen with them. And if after understanding pros and cons of all the scenarios, if they are okay with continuation of TLD, because obviously dolutegravir has benefits of prevention of mother to child transmission also, they can be continued on TLD. And if suppose they opt out of TLD, then the next option will be TLE.
Yeah. What about HIV-2 on TL lopinavir?
So when the next guidance comes in place of lopinavir, at that time those patients will be moved to TLD.
What
If at
about
all if that guidance comes, so we just wait for that guidance.
What about patient already on metformin, which is to be started on DTG? Anything to be taken care of?
Only metformin dosage need to be monitored. If it should not go beyond 1000 milligram per day of metformin. So that need to be seen. Otherwise, it is okay to give along with metformin.
I'm just scrolling the chat. There has been no mention of switch for patients on DTG, emcitrabine combination.
There has been no mention of switch for patients on DTG emtricitabine combination. DTG emtricitabine combination won't be there, so it is TLD what we will be using. So we are using lamivudine, we are not using emtricitabine. But if you are saying about patients who are on tenofovir, emtricitabine and dolutegravir from private, and if they have come to us, then obviously we will be using tenofovir, lamivudine and dolutegravir for those patients.
Need information about transition to TLD for TLE patients.
TLD to TLE transition.
For TLE patients.
So that again, whatever we discussed till now was for information. When that has to be done, NACO will send a separate letter for that, and after that only that will have to be done for transition from TLE to TLD. So that will happen later.
Yeah. Can you please repeat about IPT and DTG?
IPT, isoniazid does not interact with DTG, so there is no problem in using them together. Only issue was with rifampicin, which we have already discussed.
Yeah, thank you, sir. Those are the questions.
Okay, thank you, Shweta, and thank you everyone. I would request Dr. Chinmay if you have any closing remarks, or Dr. Reshu if you want to say anything else.
No, thank you. That was really nice. The very interactive session actually. And thank all the participants who could join in, and it's really helpful. Thank you, Dr. Anwar. That was a wonderful overview and the way you took us through. I think most of the queries of the participants you have resolved very well. I thank everyone. And any more queries, please keep writing so that we convert them into a compendium of frequently asked questions, and along with answers, we'll disseminate to all the ART centers. I thank ITech and all our other resource persons. Thank you.
Thank you, Dr. Chinmay. Thank you, everyone.
Yeah, thank you, everyone.